Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for all PHCA members in attendance. For those who provided a NAB number, credits will be uploaded shortly, and we'll also share certificates via email. As we begin today, all attendees should be in listen-only mode, so please feel free to submit any of your questions utilizing the chat icon at the bottom of your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. And now I'll turn it over to Lynn.
Hi, good morning, everyone. My name is Dr. Lynn D'Avico. I am a consultant pharmacist with Polaris Pharmacy. I'm the clinical education coordinator, and I am also an adjunct professor at Nova Southeastern University. Enough about that. So today we're going to talk about CMS medication-related updates. A lot of the new updates now have been, let me just try to get this out of here, have been because of language, not actually, new regulations. But it's important to understand this to make sure we're all on the same pages. So here are some of the tags and things that we have had language updates on, and I am going to be going over, them pretty good. So one of the things on this page is the guidance changes with clarification for fentanyl patches, antibiotic stewardship requirements, and classes of meds, as well as that misdiagnosis of schizophrenia, which we're still seeing. So first we have disposal of fentanyl patches. Now, the Food and Drug Administration said you should fold the patches in half and yes, flush down the toilet. Now, the EPA does not, I want you to see this. This is from CMS. EPS does not currently ban flushing of non-hazardous pharmaceuticals. And believe it or not, is a non-hazardous controlled substance. It is a C2, but it is a non-hazardous. Now, if your state laws for flushing pharmaceuticals is different, you may go by putting it in a drug buster, an RX ready, whatever you have as a destruction choice. What we don't want to see in your facilities is disposing it in common areas, in their rooms, and for sure not in the sharp containers. So this guidance is to prevent accidental exposure, diversion, and keep you in compliance. Now, this is from a while ago, but it has been updated in the past year that any drug that affects brain activities associated with mental processes and behaviors is the updated definition of a psychotropic drug. So we have our antipsychotics, antidepressants, anxiolytics, hypnotics. Now, CMS expanded the category of antipsychotic medications to psychotropic medications to avoid an increase in other psychotropic meds. So what they did was they wanted to make sure that we're calling antipsychotics psychotropic meds, because when you do your gradual dose reductions and you try to reduce, let's say, Seroquel, one of your antipsychotics, what was happening in the past and probably now is we would reduce the antipsychotic and then we would add 2 other psychotropic meds. So CMS is saying, that is no longer considered a gradual dose reduction. So if you're going to reduce a med, you cannot add other medications to supplement what you just decreased. And please keep in mind, opioid analgesics are excluded from this definition. We do not have to have gradual dose reductions on opioid analgesics. Now, all psychotropic drugs are held to the exact same standard. That means antidepressant, sedative, hypnotic, mood disorder, any of those kinds of meds. Now, I want to just say really quick as an aside, in the past, 3-4 months, CMS has come out now with a new guidance for the use of mood stabilizers. That's your Depakote, your carbamazepine, oxcarbazepine, all those kinds of medications that we would use for mood disorder. Well, CMS is saying, whoa, we're being heavy-handed with those medications. We're not correctly monitoring. So they want us to just really be careful when we use them. And if we use them because the resident requires it, documentation. So that's for your mood stabilizers. Gradual dose reductions and behavioral interventions are for all psychotropics, everything. So we have to try to reduce even antidepressants if it's annually every 6 months. And this is the part that I absolutely love that they finally put in writing is dose reduction should occur in modest increments over time that minimize withdrawal symptoms and monitor symptom reoccurrence. I think in the past we were getting hammered with reduce psychotropics, and a lot of us, including myself, sometimes took it as a race. We got to get them off of this. We got to do. And now they said, yes, we do, but calm, take your time, do it over time. So psychotropic medications that may have adverse consequences. Here's some examples. And when you're attempting to decrease an antipsychotic, as I said, other psychotropic meds should not increase or be added on. So, oops, I went the wrong way, didn't I? Sorry. PRN orders for psychotropic drugs, they're limited to 14 days upon initial order. So someone comes to your facility and, of course, you're coming to a nursing home. You're going to be scared, nervous, fearful, anxiety. So, yes, sometimes they put them on lorazepam 0.5, whatever anxiolytic they put them on, PRN. That's an initial order. And if it's PRN, it can only be 14 days. Now, let's say the resident used it out of those 14 days, 7 to 10 times. And you want to extend it a little longer because maybe let's try it for another 30 days or something to see how they go. That's fine. To extend it, you just document the rationale, why you want it, evaluate for the appropriateness, is it still okay for them, indicate the duration. So we got done with our 14 days. We're going to extend it to 30 days. We're going to extend it another 14 days. That's fine. Now, if you're talking about a PRN antipsychotic, so Seroquel, Zyprexa, Haldol, Geodone, any of these kind of antipsychotics, and you want to use them PRN, it is only 14 days, period. If the clinician, the psychiatrist, whoever ordered the med, wants to continue another 14 days with an antipsychotic, they must come into the facility, do a face-to-face, and then it can be renewed and only renewed for another 14 days. Very serious about psychosocial harm. And that's related to like side effects of the medications, which we're going to, we're going to keep this with meds. Sedation, lethargy, agitation, mental status changing. You want to reducing the resident's ability to perform ADLs or interact with others. Chemically sedating someone is definitely not where we want to shoot for on this. We want to avoid watch for residents withdrawing from usual social behaviors. Are you seeing the resident just sitting to the side, not coming out of their room? They used to be kind of a chatty Cathy. Now they're just quiet. Those are some of our triggers that it could be side effects of medications of these psychotropics. Decreasing cognition and avoidance to interactive activities. Now, we were talking about the schizophrenia, and one of the first places starts misdiagnosis for antipsychotic use. CMS has identified where residents were potentially misdiagnosed with a condition for which antipsychotics are an improved use, schizophrenia. This diagnosis of schizophrenia exclude residents from the long stay quality measure, which means You're not going to be having antipsychotics. You're not going to be losing stars. You're no longer, the long stay quality measure isn't going to be applying. And I think they were very generous here in saying they were potentially misdiagnosed. I know quite a few physicians. I'm in Florida, but I go California all over, and I've seen quite a few diagnoses of schizophrenia kind of all of a sudden pop up 3 months before a survey. So that can never happen anymore, and they're actually going towards the diagnosing practitioners. Hooray! And they have to meet professional standard practices. We actually have a tag F658, and that a facility assessment accurately reflects the resident status. You have to show from previous that this patient has a diagnosis of schizophrenia. Now we have training, and training in the buildings is, CMS has terms like may, should, must. Must means there's no question. You are going to do this. So you must develop, implement, maintain a training program. Make sure it's for everybody, contractual volunteers, new, existing staff, direct and indirect. Your methods can be in person, webinars, supervised practical training hours. I just listed some of the topics that CMS says you have to have. This is a must. Um, just remember, these are not optional. You must be showing that you are doing these training requirements. If you're looking for some of these requirements, like maybe, go-bys, guidelines and stuff, on the CMS websites, they do have some of these, particularly infection control, QAPI, compliance and ethics. They do have examples of some of these trainings, and they'll also have the number of hours required, etc. So, resident-centered care. The resident has the right to choose medication administration times that meet individual needs. I am seeing a lot of facilities, and I am 1,000% pro this. I'm working with CMS and ACA so that we can all be on the same page, because right now I think we're getting a little ahead of the game, which is not bad. The resident has the choice to choose their medication times. You have people that you have people that are early risers. So to have your med pass time, let's say you have it at 9 a.m., which means the nurses can pass medications between 8 and 10. What if somebody doesn't get up until 9 or 10? So we are actually changing the medications to be more of a morning, noon, and evening medication with some of the times, because you do have to explain your times in your policy for the state. So you may be saying, this medication may be given between 7 and 11 in the morning. And as long as you have documentation, you're showing that it's resident centered because this resident is, sleeping or chooses to stay up later, whatever the case is. It's not just about bathing or, other activities. It's also about getting their meds. Now, the one caveat of this is remember that they must be following the physician's orders. They still have to follow at manufacturer guidelines and time sensitive meds. If a med is supposed to be given, a certain time or twice a day, it still has to be given. You can't give sedative hypnotics in the morning. And remember, this resident has the right to choose their healthcare schedules. This is their home. And, we have to treat them with the dignity and respect that they deserve and what they would be doing if they were in their own home. So the QAPI, the specifications and standards for quality of care, service and outcomes, we know this. This is one of my favorite sentences in explaining a QAPI, and I think they could have thrown everything else out. QA is an ongoing and both anticipatory and retrospective in its efforts to identify how the organization is performing, including where and why facilities' performance is at risk or has failed to meet standards. Sums up exactly what the QA is. And performance improvement, it's the continuous study. You're going to be looking at how we can improve services and outcomes, how we can prevent or decrease the likelihood of problems. And we're going to, aim to improve facility processes involved in delivery to enhance quality of life. And I always thought this sounded like one of those little commercials. It can make good quality even better, but it is true. So for your QAPI program, hopefully all of you have a systemic, interdisciplinary, comprehensive, data-driven QAPI program that's going to be focusing on indicators of the outcomes. Now, the words in red here are the new language that came out in the past year. Systemic, interdisciplinary, comprehensive. And also that it must encompass all managerial and clinical services, including care and services provided by outside providers and suppliers. You want to identify your high risk or problem prone areas. Exceptions, might be centered around safety, quality, rights, choice, and respect. But reflect the complexities, unique care, and services that the facility provides. Every facility has their own uniqueness. Go with that. If you're a building that has a lot of found under bridge people, the homeless people, etc. If you're a building that has, a lot of people with psychotropics that are coming from a hospital or a psych division in your system, go with those and show this is our complexity. This is our unique care we're offering. This is what we're doing, and these are services that we're providing. Now, the facility must, this is all new language, and all they did was clarify so that we don't have any problems. Facility must maintain and be able to provide documentation and evidence of its ongoing QAPI program. So you have to be showing that you are collecting data and analysis at regular levels. You should document everything. If it's not documented, it didn't happen. That you're showing development, implementation, evaluation, and corrective actions. Evidence of systems and reports demonstrating identification, investigation, analysis, and prevention of adverse. So what I did here, I think there's 2 slides. These are the QAPI program definitions, and you're welcome to print these out and just, use them. You have your high risk, high volume, and high prone areas. And then here are some of your things that you could use to prevent for your psychotropic, for your QAPI. When you're looking, we need some potentially preventable events. Well, here you go. I just gave you 30. So a lot of these are very easy to do. You're probably already doing them. The instances of abuse, neglect, misappropriation of resident property, and exploitation, that was new language that was put in. Might be something you want to go with on that, just saying. But all of these are very important. And I just want to go really quick where it says care, and the last one is elopement. Here in Miami, we had a very serious event, and I don't know if you've heard of it, but it was in the news, very, very big news. A resident was missing from the home, and the nursing home that he had eloped. It wasn't his first time. They couldn't find him. They looked, and I'm don't quote me. It was either 7 or 10 days. I don't know how long. And he was found in his closet in his room in the nursing home. And yes, he was dead. My point to all of this is be honest. If you don't know where someone is, I've been in homes that actually have, and I at first I was like, what the hell are you doing? And then I realized this is so cool. They would hide a bunny rabbit, fake, all right, like a little stuffed toy. And then they would call an elopement. And the staff that, was part of the elopement team would have to go and could not come back until they found that bunny. Now, they didn't go beyond the outside of the facility walls, like, but it could have been outside in the parking lot. It could have been, wherever. And those are things that you can show that you are doing to help, potentially prevent an event. Um, Enough said about that. So we have our antibiotic stewardship. Some of the most numerous of our citations are infection prevention and antibiotic stewardship. You want to improve the resident outcomes and you want to reduce antibiotic resistance. Again, the facility must, so you have to have an antibiotic stewardship program. And now it says you should include participation of the medical director, your pharmacist, nursing and administrative leadership, and an individual, sorry, that's designated responsibility for infection control. The new guidance for your F757 and F758, this is all new language, is to ensure facility is compliant with the antibiotic stewardship program. So not only do you have to have the program, you have to have a policy and you have to show that you are compliant with your policy and your. So we want to see the CMS wants to see evidence of unnecessary antibiotic use, that you're not doing this, that you're ensuring protocols, that the infection assessment tool are in place, that antibiotic monitoring is being utilized. You're using your antibiograms from the lab that they can send you on a monthly basis, and that you are educating and giving feedback to the providers. If those of you that are with Polaris, we actually have that I developed an antibiotic program that will populate for you your endemic summary. You can even go by floor, you can go by prescriber, and all of this is right there for you. And it's on Polaris Connect and under I think it's resources, and you'll see it, and it's a big help. And you can be putting this, into your when you have your infection prevention meetings and your antibiotic stewardship meetings, which you can do together. So an antibiotic stewardship, this is F881. This is directly from CMS. You should have some components. They call them pillars. All of these should be part of it: a leadership, accountability, somebody in drug expertise, action tracking, reporting, and educating. And what they mean by educating prescribers, they don't mean to tell them what an antibiotic is. They mean to be educating them on, we no longer just throw antibiotics because somebody is urinating and it's painful. We don't just go, oh, UTI, give it to them. No, we have to choose almost like a McGreer checklist that, does the patient have a temperature? Does the patient have pain upon urination? Does the patient have a cognitive disruption? Do they have, and you can go through all of these things. And if they don't have 3 out of the 5 or 4 out of the 5, they don't get an antibiotic. And trust me when I say that I can only go with what I've known and what I see in facilities that I have and check. There's no lawsuits. There's no patients dying. We're trying to get rid of resistant antibacterials. So the more that we practice this and the more that we, instead of this knee-jerk reaction, just throw on an antibiotic, you got to be a little bit more careful than that and show what you're doing. Now, your infection prevention and control program, again, you must establish and maintain an infection control program. This has to include, remember, must, an antibiotic stewardship program, and follows the accepted national standards, and that you are doing a revision and review at least annually as is necessary. Now, infection control, the facilities must designate 1 or more individuals as the infection preventionist. They must have training in nursing, medical technology, epidemiology, microbiology. They must work at least part-time in your facility. They have to have completed specialized training in infection prevention control. Again, this training on the CMS website, it tells you how many hours. It actually has a training program for you. infection prevention must be on the facility's QAA committee, and the new language reporting should occur at the same frequency as the QAA committees, at least at a minimum quarterly. Now, we've had, this is, I think from April, it came out with the implementation of your PPE and use in nursing homes to prevent your spread of multi-drug resistant organisms. Hopefully all of you are doing this already. You already have this in place, particularly when you're talking about a patient that has a feeding tube, a PEG tube, a urinary catheter, central line tracheostomy. But I also want you to see that the providers and staff must also wear gloves and a gown for any kind of high risk activities. And that's when you're dressing them, bathing, transferring, changing linens. So, and remember, don't wear the same gown and gloves for the care of more than one person. Again, this is right from the CDC, and I pulled this right up, and that's why they're getting the credit, because I didn't do it, they did. But you can always check this out and, see it for yourselves if you want to print it out. Now, infection control, it's a system designed to identify possible communicable diseases before they can spread to other people in the facility, and when and to whom possible incidents of communicable diseases or infections should be reported, the standard transmission-based precautions to be followed to prevent spread of infections, when and how isolation should be used. This is one of the bigger problems that comes with the infection controls tags from the surveyors is isolation. Also, another one with infection control is your catheter or the urinary bag is touching the floor. Like there's all kinds of different things that we get hit on with this. So we have to identify the type and duration of the isolation, whether it's an infection agent or organism involved, and the requirement that the isolation should be the least restrictive possible for that resident under those circumstances. Now, remember that you're going to be doing hand hygiene procedures, and you want to prohibit employees with a communicable disease or infected skin from direct contact with residents or their food. Now, compliance and ethics. Remember, this is a required must-have training. Hopefully, you've already developed, implemented, and maintained an effective compliance and ethics program. And one of the things here is establish in writing ethics and compliance standards, policies and procedures to reduce criminal, civil, and administrative violations. You want to be promoting quality of care by including a contact point, which the individuals may report suspected violations and alternate methods of reporting suspected violations anonymously without fear of retribution. Sometimes those little boxes, here we have a box if you have a suggestion type thing, whatever. A lot of people aren't comfortable. They don't trust someone, and if they tell, it's going to come back on them, etc. So have some kind of a reporting area for them that they can do it anonymously, and you better not be doing any retribution. Implement disciplinary standards that have clear consequences. You don't make up these disciplinary standards as you go. Well, hers was like way worse than his. No, if somebody does a specific thing, there are clear consequences. And this goes for the entire staff. Nursing doesn't get one thing, management doesn't get another. Consistent enforcement and ensuring specific individuals, these are high-level personnel, more of your management, corporate, are overseeing compliance with the compliance and ethics, and that they're doing an annual review, and that effectively communicating compliance and ethics programs to the entire staff, contractual individuals, to volunteers. And now, if you have an organization that have 5 or more facilities, you have to do a mandatory annual training, and you have to designate a compliance officer for whom this program is a major responsibility, reporting directly to the operating organization's government body and not be subordinate to the general counsel, the CFO, or the COO. Behavioral health. This is something that I am very invested in, and I just want to say how important I feel it is. I could do an entire lecture just on behavioral health, but behavioral health is encompassing the resident's whole emotional and mental well-being. And this is, not limited to the prevention and treatment of mental and substance abuse disorders. So I read now, remember that's new language, sufficient staff who possess competencies and skills to meet behavioral health needs of residents. So you have to have sufficient staff who possess competencies and skills to meet these needs, including those with a history of trauma and or PTSD. We're seeing so much more PTSD now because of the ongoing wars that we've had. We have our vets coming back. They're not the same. And sometimes the VA is overwhelmed and they will, give them the ability to go to outside facilities, or sometimes they're elderly and they get into your facilities and we find out they have PTSD. We've been dealing with trauma histories for a very long time. We have 80, 90, and 100-year-old women, and you go back to the 1900s, 1920s, 30s, 40s. We didn't have the same treatment of women and children and anybody for that matter back in those days. And to be sexually abused or molested back in those days, one of the things you didn't do is run and tell. We didn't have psychiatrists to go chat with. We didn't have, any, you were told basically, you know, that's just how Uncle John is. He just does that, whatever. And these people would be burying this trauma for years. They get into your facility, and maybe now a little bit of the dementia is starting in, and these traumas are coming back. And they have triggers, whether it's the scent of a cologne of a man, maybe it's the sight or the height of a man, maybe it's a sound, maybe it's a million different things. But these are the things that we have to try to identify and help these residents with. A specific example, we had a resident that was a veteran that was put into the facility, and he would just absolutely lose his mind, aggressive, assertive, throwing things every night about between, let's just say, 9 and 9:45. We could not figure it out. So we actually had people in the room during that 45-minute period to see what was happening. Well, that happened to be shift change. And during shift change, and remember it's night, 9 o'clock, 9:30, it's dark. The patient, the nurse and the staff's cars and the red lights and the yellow lights and the white lights were flashing, and then you'd have somebody say, "Hey Jim, good night, see you tomorrow," whatever, blah blah blah. This guy was thrown right back as a trigger into his war zone. So it was simple enough just to black out the window during the night, and there was no need for psychotropic meds. That I'm trying to talk about. So we want to care for and treat residents with mental psychosocial disorders and trauma. We want to implement pharmacological interventions. I just give you a great example. Blacking out a window, finding somebody's triggers and avoiding either those people, those smells, those sounds that are triggering them. We don't need to be putting everybody on a psychotropic med. Not necessary. Also non-pharmacological interventions. Pets, we have our pet therapy. We have taken them outside in fresh air, your vitamin D from the sun. If you can have sitters that sit with them, maybe the family will pay a dollar for an hour or two a day. It makes all the difference in the world. But there's a lot of different non-pharmacological games art, music, just so many different things. And if assessment and diagnosis didn't reveal a mental or psychosocial adjustment or show a documented history, you have to ensure as the facility that they're not displaying a decreased social interaction, increase in withdrawal behaviors, anger, depression. So, and a resident who displays or is diagnosed with dementia, you have to make sure that they're receiving the appropriate treatment and services to attain or maintain their highest practicable physical, mental, and psychosocial well-being. Now, just an example, um, trauma, this is from our SAMHSA. Trauma results from an event, and remember, this is all red, so it's the new language, a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. That's like a huge mouthful. But this is what they're looking for, that you are ensuring that this isn't happening in your facility. And PT can occur in some individuals who have encountered a shocking or scary or dangerous situation, rape, molestation, war, an accident, a severe car accident, witnessing a death of a loved one, just anything. Symptoms usually begin early within 3 months of the traumatic incident, but sometimes they begin many years afterwards. The symptoms must last more than a month and be severe enough to interfere with relationships or work or their activity of their ADLs or just how they socialize, anything like that. Substance abuse disorder, I understand that we are not clinics, that are rehabbing people, but we want to be looking for and or drugs that causes clinically and functionally significant impairment, like if you're having health problems, disability, failure to meet major responsibilities at work or home. So remember, all of these things aren't just for your residents, they're for your staff. They're for, the people that are coming in and treating or helping or assessing or having any contact with your residents. So while we tend to focus, the majority on our residents, we also have to be aware of the staff and the people that are treating them. And substance abuse disorder is also important when you have a resident, and sometimes we get younger residents in their 40s, 50s, 60s, even not maybe 70s, that have had opioid dependence, that have been, you know, had some kind of an alcohol or, drug impairment and problem. Because when they come into your facility and we aren't aware and they aren't supposed to be having opioids or they're on bupropion and they're not supposed to be getting anxiolytic, whatever the case is, and we're not aware and we end up giving them the opioids, and then maybe they're getting it brought in from home, etc. This is something we really want to try to be doing. So your SAMHSA is your informed approach. This is where you want to realize the widespread impact of trauma and understand potential paths for recovery. You want to recognize those signs and symptoms that I just talked about for trauma. You want to respond. And I like how this is, it's through policies, procedures, and practices. And something as simple as a procedure would be when you're talking to someone, you don't talk down at them if they're in a wheelchair. You kind of scoot down. If you got bad knees and hips, you bring a chair, sit down, and talk to them level to level. You are not above them. You are not going to be condescending down to them. Just little things like that really, really mean a lot. I don't think people even realize. Now, also recognizing the signs and symptoms of trauma, you don't want to be adding more trauma. So let's say someone is having a problem communicating and you have a whiteboard for them, which hopefully you do. And now that is awesome that you have the whiteboard. But as you know, the feds have been doing these focus surveys. They come around a couple times a year. You don't know where they're coming. You don't know who's going to get it. One of the things they were looking at is communication, particularly in traumatic patients that have been traumatized. And when you can't speak, that's a whole nother level of anxiety and trauma. So if you have the whiteboard there and the person is waiting for them to write or pick, the maybe it's a picture board, etc., and you're like, oh dear God, come on, let's go, come on, um, just get rid of your whiteboard, because now you're going to end up with like an IJ tag if that's where this is going. And it's important that we have patience, we have time, commitment to what our policy is for this patient to use this. And I mean, that's just one example, but it's a big example. And I got it suggested to me from the feds that were doing focus surveys, that they had seen a lot of communication problems. Patients don't speak the language, and you don't have someone there that can help them. You don't have a way to communicate other than language with them. These are all things. Another communication part that they brought up, the feds, was if you are in, just as an example, a home that is 99% English speaking, and you have CNAs that only speak another language, Creole, Spanish, Russian, whatever it is, they should not be speaking that language that the residents don't understand. It can cause a lot of anxiety, paranoia. These are elderly people. These are people that are like 2 steps from dementia. Maybe they already have moderate or mild dementia. So when they hear something that they don't understand, they get nervous, they get upset, so communication, this is all the way around. Now, the 6 key principles of a informed approach are safety, make everybody that's involved feel safe, that there's trustworthiness. If you say you're going to do something, you're going to do something. Transparency. This is what our plan is. You can come look at it. You can see it. Do you want to add something to it? Is there something that we're missing? Peer support, that not only we have peer support, um, nurse to CNA to dietitian, whatever, but everyone has, even the residents. Collaboration and mutuality, empowerment, voice, and choice. Once again, we're to that choice that I was telling you about: medication choice, choice of when they're going to shower, choice of who their physician is, choice of, what they're eating for dinner. They have choices. Um, Empowering them so that they feel like they mean something, that they're not just a piece of paper. We're treating people, not pieces of paper. That if they are, alert and oriented to a certain degree, that they have a voice and you're listening to it. The food really was awful today. Usually it's bad, but today was like seriously bad. Or, I really don't like when this patient or this person comes in my room. We're listening to them. We're also going to be understanding some cultural, historical, gender issues. If someone, and I always use example because I'm Catholic, so if it's Lent and we don't want to eat meat on Fridays, or we have a certain fasting time, which there are quite a few cultures that do have fasting. Some want kosher, some want this. If you're accepting these people into your facility, then you must, not may, you must conform and help them to be comfortable with whatever it is they're doing. So these are some of the things that I have put on for you to look at. And if anybody has any questions, I would be more than happy to
Yep, just as a general reminder, if anyone does have any questions, I'm not seeing any in the chat at this moment, but as always, please feel free to email myself or Lynn. If you email me, I can forward the question to Lynn and she'd be happy to answer that for you. And I think that's all for today. And Lynn, we appreciate you.
Okay, I wanted to tell you, Kimberly, that I also sent you a copy of my PowerPoint.
Yep,
So,
I'll be sharing that when I send
okay.
the certificates.
Yeah, if anybody needs it, and you have my email, so if anybody has any questions or concerns, I know I'm like 5 or 6 minutes early done, but thank you. I appreciate you having me.
Thank you. Thank you, everyone. Have a great day.
Bye. Happy
Bye.
holidays.